want to welcome all of you to joining us today to the BC Provincial Summit on Aging Preview Keynote series, What is Social Prescribing? Really excited to have all of you here today. These teaser series or sessions are a preview to our Provincial Summit on Aging, which is taking place next spring in April, hopefully in person. And we're actually offering 2 more of these webinar teaser events this fall. We will add the registration information into the chat, so you can take a look at that, and I'll provide you a direct link if you are interested in joining us. November 2nd, we'll provide a glimpse of the men's shed movement from around the world. And on November 16th, we're going to hear about Frome's Compassion Project. And again, the dates and the times will be added to the chat for you for ease of reference. My name is Bobby Symes, and I'm the Assistant Director at the Population Health Team at the United Way of British Columbia, and I will be moderating the panel discussion and questions for today. Before we start, let's take a moment to acknowledge the land on which we are joining. Today's webinar hosts and panelists acknowledge the traditional, ancestral, and unceded territories of the First Nations of all areas of British Columbia, on whose lands we gratefully work and gather. Personally, I acknowledge that I'm hosting this webinar from my home on the traditional, ancestral, and unceded territory of the Coquitlam First Nation. We thank the Coquitlam who continue to live on these lands and care for them. We welcome and encourage you to also share with us where you are joining from in the chat box. Please take a moment and do that as I go through a few housekeeping needs, which I'm sure you're all familiar with by now. All participants for today's webinar will remain muted with cameras off. We have reserved some time before the end of today's sessions for your questions. So at the bottom of the screen, you'll see a little Q&A feature. Please add your questions here and I'll read them out to our panelists on your behalf. If there's a particular panelist that you would like your question directed to, please add their name to the front of the question. Otherwise, I will go ahead and choose for you. Today's webinar will be recorded and posted on our Core BC platform. If our presenters have any slides, we'll also make sure that those are shared for your reference. So today's agenda, we only have an hour, which is not long enough for the breadth of knowledge that we have with us today. We have asked each of our panelists to provide a high-level overview of their program in their region, and this will be followed by moderated questions to the panelists. And we will then open it up for questions for today's audience. And with that, I have the absolute pleasure of introducing you to today's panelists. We have Dr. Anne Essam. She's joining us from Watford in the UK. Dr. Essam is the clinical lead and ambassador for social prescribing in the United Kingdom. Dr. Essam is often referred to as the godmother of social prescribing, and we're really thankful and pleased to have her here today. Following Dr. Essam will be Sonia Hsiung, joining us from Ontario. Sonia is the project lead at Alliance for Healthy Communities, a network of team-based primary healthcare organizations. And finally, many of you might already know Dr. Grace Park. She's from here in BC. Dr. Park is the Regional Medical Director for Fraser Health and has been instrumental in setting up social prescribing here in our province, and is someone that I refer to as our champion. Each of our panelists will speak to social prescribing in their communities and offer us a peek to what social prescribing is internationally, nationally, and provincially. Dr. Essam, I will turn it over to you. Welcome. We're so happy to have you join us today.
Thank you so much. It's such a joy to be here today. I'll let you into the secret. It's my birthday. So there you go. I am speaking to you on my birthday and I was delighted. So talk about social prescribing on my birthday. That's how much I love it. Okay. So for me, 32 years, a GP in the United Kingdom, social prescribing came across my desk about 8 years ago. Honestly, the most exciting, transformative, meaningful treatment I have ever had to offer any of my patients. The reality is that all the wonderful science I learned and appropriated in medical school and my subsequent training misses probably 80 to 90% of the determinants of health of the patient in front of me and their family and their carer. Medical bit will always be important, and you need your experts in that field, but you need your experts to have a much wider lens and a bigger heart to be able to embrace the other aspects of people's lives, things that matter to them and things that help fulfill their own personal potential. And in Canada, you're very good at recognizing those social health determinants, housing and finance and connectedness and a purpose. So many different things make a huge difference to your well-being. And what I found is, while we might notice them in our conversation with our patients, we are ill-equipped to do anything about any of that. And so the social prescribing system, which in the UK comprises expert link workers who are able to have a long conversation, mapping out what really matters to that person, the obstacles they have, the unfulfilled dreams, the strengths, the difficulties they've encountered, often difficulties encountered on account of a siloed, complex system around them with health and social care. They've not been able to navigate their own way to finding the help they needed to overcome the difficulties, which have kind of layered up one on top of the other. And those difficulties, those social health determinants, rob them of hope and generally sap away their motivation so that they don't kind of believe life could ever get better than it is. So these people don't even access the medical bit of the healthcare appropriately. Sometimes they will somatize social symptoms and keep coming with a vague pain or peculiar symptom you can't really put your finger on, but could potentially be something worrying. So you investigate it and you spend time with this patient, and all the while they're just glad they're there and you're caring. You've actually missed the point entirely. Once you start to honestly face the fact that there are social health determinants and you offer the person that kind of conversation, that kind of relationship that takes them into their personal space of exploring how life got in this pickle and how we might build a route map out of it to a much better future, what we find is that hope arises afresh and people become determined and motivated to engage with their link worker and are happily introduced to a new community group, to debt advice. They're happy that the link worker might be their advocate with a housing association if maybe their housing is really quite a mess and they've tried to get an improvement and been rebuffed for whatever reason. So the link worker is a mixture of coach and advocate and just a bringer of hope. I mean, I can't use that word too often because it is mission critical. If you don't have hope, you're not interested in the risk factors that your medical history may present, because actually you're not worried whether you're going to wake up in 10 years' time or not. You're actually kind of hoping you don't. And there's that kind of anxiety and fear that all intermingles as we unravel the social health determinants, deal with the hoarding, deal with the broken relationships, sort out the benefits, connect with the community, find that actually a walking group leads to friends. A men in sheds group means that even men can stand shoulder to shoulder, not actually eyeballing each other too much, but with a sense of companionship. And they might even unburden themselves of some things that have been worrying them. This kind of relationship with these extra relationships that build on top lasts typically 3, 6, 9 months, sometimes longer. And progressively, the social prescribing link worker empowers the person to consider with a more resilient attitude how they might overcome each hurdle. And at the end of the journey, the individual is much better able to deal with difficulties that arise. Their attitude to him has entirely changed. They are positive, hopeful, and they know that there is a way. Even if it isn't obvious, there is a way, and they will find it and they will grow through it. I've seen so many people change. I've seen people back to work. I've seen people whose loneliness is over and they have a purpose and a joy in every day. When I get my next 3 minutes, I'm going to tell you a story, but I didn't dare launch into a story within 7 minutes. So in Canada, the rhythm of social prescribing is a little different, but it works beautifully. And you're going to hear about that next. Thank you.
Thank you so much, Marianne. Always so inspirational and such a joy to hear you speak. Sonia, I'll pass it over to you.
Okay, great. Thank you so much. And Marianne, like we worked very closely with Marianne and her colleagues when we started social prescribing in Ontario. And let me just tell you what it looked like for us, because I think Marianne has really set a beautiful context from that. So we implemented a social prescribing research pilot in 11 communities across Ontario that we called prescription community, so RX community. And so to give you a bit of context while the slides are coming up, the Alliance for Healthier Communities is a network of over 100 community-governed comprehensive primary healthcare organizations. And so that includes community health centers, nurse practitioner-led clinics, Aboriginal health access centers, and community-led family health teams. So the organizations are focused on serving people who have complex social and medical needs and face higher barriers to health. And they're team-based, so they typically deliver a range of clinical, allied health, health promotion, and social and community support services. So if you think about a family's doctor's office nestled within a community hub, that's kind of what it looks like. So what it looked like for us was relatively similar actually in the UK, and that actually emerged a little bit organically, because we implemented our research pilot in a mix of urban, rural, francophone, and northern communities. And because of the diversity, we said, tailor it to what works for your community based on your resources and needs. But these are the 5 components that emerged really as core. So we have the client, of course, a person who has these social and medical needs, but are also people with gifts and passions and their own goals. We have the prescriber, so in our case was leveraging the primary healthcare doorway, primary care providers, as well as the interprofessional healthcare providers, to help identify when a person makes a healthcare appointment, say, oh, they also have other concerns and issues that would be better addressed non-medically. And then if so, as Marianne said, they're not the experts in those things. So they connect people to a navigator, a link worker, who is that person who can do that person-centered navigation, understand a person from an asset-based, equity and trauma-informed perspective, and then to connect these people and co-create solutions with them to the social prescriptions, the interventions, the programs, the activities, the services that will support the social determinants of health and to help a person reach their self-identified goals. And of course, over all of that, for us was important to track the data, to be able to follow the client's journey and to assess what the outcomes and impacts of this kind of pathway has. So a very quick story about Sarah to help illustrate this pathway. So Sarah, who's 60 years old, comes to see her doctor and shares how she feels lonely. She's been housebound and she's really struggling with managing her own mental health. The doctor, along with checking up on the medication, refers Sarah to a navigator. Navigator meets with Sarah, and turns out that creating art is something that really brings Sarah joy. So the navigator, along with other staff at the health center, helps Sarah to start a community art making group. And word spread to other clients, more people joined, and Sarah now facilitates a weekly art group on her own with very little staff support, using space at the health center. And the connection she found really brought someone who is housebound and socially isolated into a supportive, purposeful, and skill-building role in her community. Now, when we pulled the data, in the 2 months prior to forming the art group, Sarah made 5 visits to her doctor. And in the 2 months after the establishment and kind of the this art group happening, Sarah has only visited her doctor once. And so Sarah is really a composite of many of the stories that we hear emerging from social prescribing. And some of this is not necessarily new. I think when you hear this, maybe you're thinking, like, this is something we already do. And organizations within our network have been meeting people where they are at, have been navigating people to non-clinical services. But what social prescribing does as a formalized pathway is it provides an intentional structure that is clear, it's standardized, it's replicable, and it's measurable. And I also really want to emphasize that aside from this wide range of integration between clinical, social, arts, culture, nature, and all these other sectors, the importance is co-creating the solution. And that is where we really see that increase in sense of purpose and belonging. And if you can go back one slide to, thank you. So we were able to follow some of these impacts. So there's that sense of purpose and belonging that's really hard to measure and was actually something we didn't expect to see and didn't measure. Where we also captured significant decrease in people's sense of loneliness, an increase in the sense of mental health and participation. And on the healthcare provider side, which is the next slide that you saw earlier, over time, healthcare providers really began to see the impact of this on their clients' health and well-being, and also saw decreases in the number of inappropriate visits that people were making. So as a next step, COVID really necessitated a lot of pivoting. So we have pivoted to virtual, creating safe virtual spaces for older adults. And this is on the next slide. People were sending boxes of crafts, boxes of food, trying to do virtual programs. And building on what we've learned, we're also embarking on a new project called Links to Wellbeing that is specifically around supporting older adults and building a connection between healthcare settings and older adult centers in Ontario, and connecting older adults to programs and activities in that way. So just very quickly, finally, I want to leave you with some of the key lessons that we learned. At the next slide, I won't go through all of those things in the slide. You will have the slide, but communication is key. Having clinical champions and peer champions is really important to building knowledge base and encouraging people. Supporting and following up with the clients is important. And being open to culture change, shifting our view with clients and the way we work with them to, asking what matters to people instead of what is the matter with you. Having a common language and building long-term processes is what will make this systemic and sustainable. And so I'll leave it at that, and over back to you, Bobby.
Thank you so much, Sonia. And sorry about the confusion with the slides. I'm glad we got all that sorted out for you. Grace, I will pass it over to you.
Thanks. Mic is on, I think. You can hear me? Yeah. Good morning, everyone. I'm really thrilled to be here with my other 2 guests who are offering lots to learn. I just wanted to talk to you a little bit about what we've been doing in BC, specifically in Fraser Health, which is the southwest corner of BC. Work we started was with the GPs in the communities, working with divisions of family practice that represent the GPs in the communities, allows us to interface with the group of doctors in the community. So we went to them with the idea of healthy aging, but pitched it through frailty prevention. So preventing frailty leads to healthy aging. And we know from research that there are things that you can do now to prevent frailty and even, mitigate the frailty progression. And so along with that came the idea of social prescribing, because we know how important the social issues are in seniors' health as they age. So this all happened through partnerships, first with the GPs, going through what it takes to measure frailty in the seniors, and then things that we can do to mitigate that frailty progression by measuring frailty again over time, like a year later, using comprehensive geriatric assessment tools. And doing that, we talked about wellness planning as well as medical care planning. So wellness planning addresses things like Marianne was talking about, what's really important to them, what makes their life meaningful. And in partnership with United Way and our community-based senior services organizations, we identified people in the community organization that are the link workers, except in BC, we call them the Seniors Community Connectors, the SCCs. And because our system is designed where health is completely separate from social, we needed to really work hard to bring those two sectors together in an integrated manner. So our seniors community connectors are more than navigators. They have full knowledge of what's available in the community that they can actually offer the primary care providers, the GPs, but they're also expert in doing that in-depth interview over time. And it can be with the senior alone or with the family caregivers as well, to understand what the barriers are for them to reaching out, to connecting with community organizations. Is it physical? Is it cultural? Is it financial? Is it psychological? So through that in-depth conversation, they can tailor make an appropriate connection to the community and then support them to get there. So if it's transportation, that can be arranged. If they need somebody to go with them to a beading class or a hula dance class, they do that. And so that initial connection and support was hugely helpful for our seniors to get out there and get connected. And so that was in the community, the primary care world. And then now from Fraser Health, the deliverers of health services, and all motivated to try and keep the seniors as independent for as long as possible in the community, we're forming partnerships within Fraser Health with our seniors community connectors as well. So our community nurses, our home support care workers that work in Fraser Health are going to be meeting with the seniors community connectors to talk about what else they can be provided to give the seniors more purpose and that resilience. And then at discharge planning, and this is the most exciting piece that we're working on now, is to bring the seniors community connectors into the discussion at the time of discharge for seniors from hospital, where often they've spent many weeks in hospital, lost their community contacts, they need help to get groceries in the house, they need help to pick up their prescriptions, and they need help to feel strong enough to connect back out into the community. And so we also know that there are a lot of social factors that lead to slower convalescence and reduced ability to regain back to baseline. So we're very excited about launching this discussion in a few of our communities to talk with the seniors and their caregivers, with the seniors community connectors in that community. So the outcome that we're hoping for is, of course, better utilization of healthcare resources, optimization and bringing the right care when necessary, but really trying to prolong that independence and the feeling of purpose and belonging in the community for our seniors, and ultimately improved quality of life. And I think that might be my 5 minutes, Bobby.
Thank you so much, Grace. You're all so absolutely inspiring. It's always a pleasure to hear you. There's so much power in the stories that we're about to hear, and to be honest, it's those stories that I hear almost daily. Whether it's a struggle with a community connector that they're having working, and they're working through that with other community connectors in a community of practice, or hearing from a program participant on the impact that their connector has had on their life. I'm going to ask each of our panelists now to share a story or a moment that resonates with you, a story that keeps you going in this work. And Marianne, I know you're itching to tell a story, so I'm going to start it off with you.
Okay, so we put some of our link workers in the integrated discharge teams in the hospital. So when we saw that people were attending frequently and we wondered why, we could actually send a link worker back home with them to look into things at a greater depth. And there was this lovely gentleman in his early 70s with quite advanced Parkinson's who kept turning up to the hospital with crushing chest pain. And of course, anybody goes with crushing chest pain, all the necessary cardiac tests must be run. He'd been 7 or 8 times, and every single time there was nothing wrong with his heart, but they spent all of the money and all of the time doing the necessary tests, then sent him back home saying, there is nothing wrong with your heart. So our link worker spent just over an hour with him. Generally, the first conversation takes about an hour and a quarter, we find, to get the person relaxed to a place to being able to start to talk. And she said to him, look, I'm not a doctor. If you get crushing chest pain, you must go to A&E. Never let me stop you doing that. But can we have a chat and can I get to know you? And can you explain to me a little what precedes this chest pain? And it transpired it was mounting anxiety. So she said to him, okay, I can understand that's really stressful. Can you explain to me what makes you anxious? And she started together with him to unpick these situations, and he reflected what had triggered each visit to the hospital. And between them, they identified, I think, 7 or 8 causes of anxiety. And some of them were quite easily solved with a practical solution. He was worried about getting to his hospital outpatients as he wasn't able to drive, so she hooked him up with volunteer transport. He was worried about his mobility around the house as he was getting more shaky. She was able to set the adult care services in motion to put in the necessary rails. He was interested and reflective regarding the sort of the mounting fears and feelings and thoughts that came upon him in any of these situations, and was willing to accept a referral to psychological therapy to understand the mechanism of his own anxiety. But the most incredible thing, he pointed to an old dilapidated sofa at the edge of the room, and he said, you see that old sofa over there? My wife and I used to sit in there and hold hands, and together, whatever happened in life, somehow we'd muddle through and we wouldn't get too worried about it because we had each other. Neither she or I can get in or out of that sofa anymore. So we sit on dining room chairs at opposite sides of the room and we worry at each other. Now, because link workers have a wonderful way of knowing where there is a grant or a philanthropic piggy bank, money was found for a new sofa into which he could get and get out with his wife, no problem at all. And the anxiety levels dropped right down. And this lovely gentleman has not had chest pain or needed to go to the hospital ever since then.
Thank you so much for sharing, Marianne. What a beautiful story. Sonia, over to you.
Not as good a storyteller as Marianne is, but I love the stories of where people have been invited in to co-create the solutions. I think by and large, that is the most powerful ones that I have encountered in our work in Ontario. So we have this group of champions, they're called health champions, in Centre Santé Temiskaming, which is a francophone center, kind of north rural Ontario. And these group of people were invited in from the community and from clients to say, what are your gifts? What would you like to see in this community? What are the gaps and how would you like to contribute? And they started a number of things. They started clubs, they started friendly visiting, they started like a pet support program to look after each other's pets when people have to go into for healthcare appointments, which are things that the healthcare provider would never have thought about. But this one gentleman told us this, and this is the quote that I absolutely love, and I think it really captures the power of this, is he says this: after being laid off, I had lost my pride. By getting involved, I was able to fight my isolation while helping people in my community fight their loneliness. I am now proud of myself, knowing that I offer others the chance to follow this good prescription, that of putting life into our lives. And I just love that so much.
Thank you so much for sharing that, Sonia. What a lovely story. And Grace.
Yes, I have a story that comes to me from one of our seniors community connectors. She had a client who had been declining for many years. She had lost her husband a couple of years prior to meeting her, and had basically given up, was actually suicidal, really felt there was nothing more in her life. She had lost touch with her older children, and she had nobody in the community that she was connecting with on a regular basis. And she had a lot of chronic medical conditions as well that she couldn't keep straight. She had so many doctor's appointments in her calendar, she really couldn't keep straight at all. So Sandy, our seniors community connector, talked with her on a few occasions, and gained her trust and friendship, was able to go into her place and talk to her about what was going on in her life, and organized her medical appointments so that it became a little bit easier for her, even went with her to some of her doctor's appointments that she was nervous about. And then she learned that the landlord, and she was living in a basement suite, was threatening to raise her rent. And that would have meant that she would be homeless, and that would have been just the end of the world for her. So the connector actually applied to a community funding source of some sort, and she was able to come up with the money to help her, to support her for rent for a short period of time. And so that stabilized this lady, and it was really tremendous help for her. And then even after that, she had required a lot of dental work, couldn't afford much of it. So the connector actually went to the community chest and was able to find some money so that she could get her dental work done, which was really helpful in stabilizing her health as well. And after that, she actually connected her to the seniors center, where she was able to make some friends and start talking about her life a little bit. Even went to a Christmas party where she was given a Christmas gift that was donated, a winter coat, and she was actually in tears because it was the first time she had actually owned a new winter coat. So really heartwarming stories. And this connector actually talked to her about what other things she might want to do, so helped her to connect with the hula dancing class, and went with her to do the first class because this lady was feeling shy about going for the first time. And Sandy, the connector, said after she'd taken her a couple of times, she knew that she can go now on her own because she was able to talk to other friends and she was feeling comfortable enough being there. And that's that resilience that develops with social prescribing and the connection to the community. So we were really thrilled about that. And she was also connected to the local food bank, where she was just eating tins of tuna before and had emaciated. And she has now gained back 5 pounds and doing a lot better. So that's my story, and really heartwarming.
Thank you so much, Grace. Thank you to all of our panelists for sharing those. I have goosebumps, and I've seen a few comments in the chat about the same thing. Your stories make me proud to be part of this movement. We'd be remiss, though, to acknowledge, and I think Grace just alluded to this, the true champions here are the work of those on the ground, those on the front line doing the heavy lifting in community. And that's those community connectors, those link workers, those navigators, whichever title that they hold. My next question is, as a leader seeing firsthand the benefits of social prescribing, what advice might you give to a community connector, link worker, navigator about the impact that they have on the population that they serve? Grace, why don't you go ahead and start off?
The impact is tremendous. And I talk about the changes that actually happen at the cellular level in our brains when we're able to make connection with people in the community, and the mind-body connection, that when your mind is healthy, your body can be healthier, and that tremendous impact that it has. And so the social connection is hugely important for the seniors' health. And we've recently got a study that showed that even mild to moderate exercise, like walking and gardening, and learning things like doing arts and crafts and joining with people, decreases the cognitive decline that we often see with dementia patients. And so huge, research and evidence that shows that what we're doing with social prescribing makes a difference for our seniors' health. So what you're doing as navigators and as community connectors, link workers, has a huge impact on the health of that individual and the community. So that's sort of what I encourage you to think about. And I know it's difficult sometimes, especially in BC, to try and make the connection to the healthcare sector. But with the work that we're doing here with United Way, hearing stories from Marianne from the UK, we're raising the profile for social prescribing. And so pretty soon, the GPs are going to hear about it from their patients. And I think that will be the full circle. When we can get our seniors to know about social prescribing and actually ask their GP, can you write me a social prescription? Then we know we've done our work. And we'll move on.
Thanks, Grace. Sonia, I'll pass it to you.
Grace, I love that you mentioned that, because that is what happened in Ontario. So when social prescribing hit the news, we had people calling me to say, I got my doctor to give me a social prescription. Now what? And it was fantastic. It was a fantastic problem to have. And I think I don't know that I need to emphasize any more of the importance of the community connector, which is really such a linchpin in making this work. I think perhaps my advice and encouragement is to capture the data. I think we hear so many wonderful stories, and I think intuitively people know that this works. But for some reason, we need to talk to other players in the healthcare system. We do need to be able to share the stories more widely. And so I think being able to track the data, to evaluate in a robust way, being able to follow the client journey through intervention and outcome, to pull out what is the magic in the work, what is the kind of conversations you're having that makes it work, helps tell the stories, helps make this replicable, and help us to be able to advocate for sustainable resourcing and to really transform at a systems level how healthcare and social supports get interconnected and are delivered across our provinces.
Thank you so much, Sonia. And of course, last but not least, Marianne, I'll pass it back to you for words of inspiration.
Okay, so population health, one precious individual at a time. If we think of a population, you can't just change the whole thing. But the joy of the community connectors is you do change population health, but you do it person by person by person. And that affects their carers and their families and the communities, and they see the transformation. So it's incredibly powerful, and it does scale up, but never lose sight of it being a personal, individual intervention. That is critical. And if you feel under pressure from doctors saying, oh, I've got to show population health improvement, stand your ground. Yes, you will see it, but let me deal with your patients one at a time. The other thing I'd say is, though, which is sort of the flip side of that, is you may, with your GPs, identify particularly at-risk groups, people, I don't know, bereaved by COVID, different individual groups that you could look at reaching out to. And although it is an individual reach out, you are looking at a particular population group. And that could make for quite a nice little study in terms of common denominators that you found and particular solutions that you found reached a number of those people. Yeah. So that gives you a little more, if you like, the population demonstration for your clinicians. There you go.
Thank you so much, all of you, for those words back to our community connectors on the impact and importance of social prescribing. We do have some time for questions from the audience. So I will encourage, if you're on the line and you would like to ask any one of our speakers a question, now is your time. And you do that by going to the Q&A feature down at the bottom of the panel. We do have a couple in there, and so I will go ahead and read them out. First off, we have, it looks like Maisie. She says, hi from England for Dr. Marianne Essam. Do you ever get patients who are skeptical about social prescribing? And what do you do in that case?
Okay, I think it is, it's helpful having a relationship with the patient. I think it would be difficult to introduce it to them without personally having a relationship with them myself. But because my patients trust me, then I've got that incredible privilege of a validated introduction to social prescribing. The term is a little quirky, and I'm not even sure it's the right term. I know that for some people, and particularly in some of your communities in Canada, the word social would be a complete turn-off. And the word prescribing, does that describe it? What you need to do is actually unpack it with the individual that you're referring to and explain that actually I'm only good at the medical bits, and there are other things that are definitely impacting on how happy you are and how fulfilled you are. So let's have a look at those things, because those things are important and we don't want to overlook those things. And you'll probably find that the work you do with me on the medical bits becomes easier and more meaningful. And certainly that's been my experience. People accept referrals, they look at their medicines more usefully. They'll actually come and say, actually, I'd like a referral for some rehabilitation, volunteering it. People have come and said, right, I've decided the time has come now, I'm going to stop smoking. So they become engaged with their health in a different way. So you can promise them, you know, you're still there for them as their medic, you know, you're not letting them go. And, you know, I think that is enough to give them the courage to take the first steps.
Thank you. Lots of questions coming in, so I'm going to try and get through as many as we can with our speakers, but please don't feel discouraged. If you don't hear your questions, we'll compile a Q&A and we'll make sure that everything that's been posted does have an answer eventually. I'm going to pose this question to yourself, Grace. Rebecca asks, from your experience, do you think it is necessary to build out from the community physicians first, and then segue into discharge planning for a seniors program, for example? Or could something similar be started in partnership with the health authority and the senior community connector at discharge? I have to, oh, then she goes on to say she's just attending another meeting.
I have to go to another meeting too. We're doing it both ways. And so we did it from the primary care side because, you know, most people have a GP. There are many that don't, but our seniors hopefully are mostly connected to a GP. And so that's why we went to a GP. And also because the GPs are aware and have a relationship with some of these vulnerable seniors. But we know that there are many seniors that are isolated because of the way they are psychologically, or they're just not willing to connect. And so from the health authority side, we've actually started working, you know, directly from the health authority side, looking at patients that are cared for by community health nurses, and then referring directly from them to social prescribing. And then we've also gone into assisted living sites, and we have a program rolling out there in assisted living under Fraser Health, where patients are identified by rec therapists at the site and then referred to their local seniors community connector. So it can be done from the health authority side. We just did it from the GP side to start with because we had a frailty program, and that's where we actually even thought about having the social prescribing as a component of senior health.
Great, and I'll pose the next question. You know, maybe each of you can touch on it just very briefly, but it's around the qualifications of a link worker and how does one become a link worker? Grace, since you're already on screen, I'll send it to you, and then Dr. Essam, and then Sonia.
So when we worked with our communities to develop the social prescribing scheme, we worked with the health authorities. So that was me and my team in Fraser, worked with Bobby and United Way, and then the division of family practice in each of our communities. In Fraser Health, we have 10 divisions of family practice. And between the three bodies, we came up with a list of criteria for identifying an organization to hold the position of the community connector. And that organization was chosen by the three bodies. They went and hired, and we have a job description. So we don't have a specific professional status related to that, but it's whoever is very aware of the community, who feels comfortable working with the physicians in the community. Some of them have nursing backgrounds, some have social work, some of them have psychology background, but they are drawn to this role because of their willingness and wish to work with seniors. So I think that's where we started, and we're probably going to look at all our link or community workers through the community of practice, and probably start looking at what kinds of roles might be better for the future. But that's how we started. Thanks.
Great, Anne.
Okay, so I think one of the most important characteristics is whatever professional background they've come from, and that could be social work, probation, nursing, third sector, could be one of all sorts. They always saw that they could have gone further, but the criteria or the capacity didn't allow them to do that. They have that vision of the second mile, maybe even the third mile, and they want to be able to go that whole distance with an individual, not just to signpost them, but to see them transform. And that incredible tenacity and vision and belief in individuals, we look for that. So, for instance, I recruited a couple recently, and there's a gentleman that's had extensive experience in housing and working with homeless young men. But the thing that really told me he's going to make a good link worker, he's also been a foster parent. And one of the kids that came his way was a young lad that really had a lot of problems and wasn't going anywhere. So they adopted him. And this young man has now graduated from university, having overcome all sorts of previous traumas and subsequent obstacles in his own journey. And I knew that this chap has got what it takes to see the gold or the treasure in somebody and believe in them until they start believing in themselves. Obviously, we give them a lot of training once they arrive, and I helped NHS England write some of the online modules for that, so that they're all up to speed with all the mandatory things, the safeguarding things and coaching skills and different ways of framing conversations and firming up a personalized care plan, which is really owned by the individual. Mental health qualifications, recognizing suicidal risk. And I think in time, what we will do is we will have specialists within our fleet of link workers, because what the team say is, we like to talk to one another about our cases. And if different ones of us have come from different backgrounds, that really we know who to go to when there's a problem with housing, there's a problem with mental health, etc. And so they have such a resource for one another. And it was in fact our little team that said to us, please recruit the next one with a housing background. So that was a deliberate look for somebody, rather than having to go to the housing associations all the time, who can be a little obstructive, wanting somebody on their own team with all of that understanding behind them as a resource for the link workers. There you go.
Thank you. And Sonia?
I think it's all been said very well. It is much more principles and approach based, I think, rather than role based or training necessarily. In Ontario, we did not have funding for these dedicated link worker or navigation roles. And so in many cases, we repurposed existing staff roles, and they are from a wide variety of backgrounds. And I saw a lot of chatter around recreational therapists, and absolutely, it's a great alignment with the fit. And so and so that's kind of what we did in Ontario. And I think there is capacity within the system, but that role is key to be resourced for sure.
Thank you, Sonia. And we'll stay with you because the next question I'm going to pose is around data. And if Grace and Marianne, if you guys want to comment on this as well, but how is data being tracked, measured? How are these programs being evaluated?
Okay, so a couple of different things. So we have certainly we track the process of it. What are people connected to? For what reasons they're being connected to? The social demographics of the people that are being connected is really important to know who is benefiting from the services and who may we be missing, who is not among the group. And so those are the pieces of kind of the referral pieces, and what are people being referred to, what interventions they're participating in, and then the outcomes. So we relied a lot on self-reported outcomes. We asked questions around self-reported mental health, physical health, sense of belonging, sense of loneliness, and sense of and social participation. And so those were the kind of key indicators that we focused on for our work. But there is in the UK a fantastic document that is sort of all of the different types of self-reported patient-reported outcome measures that could be used for a wide variety of things you would like to evaluate.
Thanks, Sonia. Grace, any comments?
We're kind of trying to wrap our heads around how do we collect data, and Fraser Health, of course, is like completely data driven. And so with our programs that we're doing within Fraser, with our assisted living, our discharge planning, and even community referrals for social prescribing, we're actually going to work with United Way with their database, their iUnite, because they do an intake process with all the referrals that are sent to our seniors community connectors. And so that's another beauty of our partnership, is that we're able to share aggregate data, and we'll be able to see, you know, how many referrals are going through, what kinds of people are coming through, what kinds of programming was made available and connected to the seniors. So we hope to have that, but definitely on board with tracking data.
Marianne, any words on data?
Okay, so the way we did it in the UK is we kind of did the business and then thought, oh, whoops, we'd better have some data here. Sonia being Sonia said, yes, we're going to get this started, but we're going to get the medical records all ready to be able to catch it as we go. So honestly, you guys know more than we do about data tracking. I think our challenge at the moment is really trying to create enough appropriate read codes in the medical records and get them into use. We're experimenting with various templates. What I would like is a read code which states a particular social health determinant, housing problem, financial problem, isolation. And then I'd like a read code that says financial poverty resolved, or housing issue resolved, or, you know, the flip side of each one, so that you could actually look and see what sort of incidents in any particular an area were there, housing, debt, etc., and what sort of percentage shift through your social prescribing intervention you have seen in those particular social determinants. We are a way off of that yet. We're also looking to try and capture which organisations were referred to. That will also help us plan capacity. But again, you have to be a little bit careful flooding the market with things to count, and work out what is it you really want to describe, which will help you intelligently demonstrate what you're doing and what you need to do to make it even more effective.
Thank you for that. I'll just a couple of questions that have come through just around, you know, what's happening here in BC, and I'll provide a little bit of context on that because we have a number of people in BC. So United Way of British Columbia, with support from the Ministry of Health, like most of our programs are, was provided funding to get back out into community through our social prescribing program. So we currently have 19 funded programs across the province, 9 of which are in Fraser Health. We were looking at a specific model under Grace's leadership there. And then we have 10 that are scattered throughout the province. And so it is a separate program beyond our Better at Home program or other traditional programs that we might have, specifically looking at frailty in older adults. I did see another message that came in for BC to you, Grace, about why just seniors. It's just seniors right now because it was a specific mandate. The funding was targeting frail older adults and how we can continue to keep them at home and in community. We know social prescribing is a benefit across demographics, but right now for these demonstration projects through the Healthy Aging Department, United Way, with Fraser Health and other programs throughout BC, we are targeting seniors and older adults in community. Just monitoring the chat here. Lots of great comments and questions, lots of support. So there's coming in. We do have a question. Oh, and this is a great one. And it's something that I know we've become very conscientious of as we were rolling out, but I'll put this out to all three of our speakers just for some final comments on this. Have you reached out to the nonprofit sector with regards to capacity to support people with disabilities in volunteer roles? If so, what was the response to potentially getting more volunteer referrals through social prescribing? Comments? Marianne, you're up on the screen. Can I start with you?
Of course, the capacity of the voluntary sector is mission critical. You can't be sending people to the community for prescriptions if there aren't enough prescriptions there. And you do need to look as a system as to how you are shoring up your community resources. Some of that you will enlarge by increasing volunteering, even as a social prescription, as people bring their gifts and strengths into the community. But you also need money as well as social capital. And I would say we're on a journey here in the UK with the National Academy of Social Prescribing, demonstrating how you can fund different community initiatives to generate some momentum. Personally, I think corporate social responsibility is a way to go, because you'll have major employers in any particular community, and the logical thing is, if you are creating resources even for the seniors, the employees in those places will be less worried about their mums and dads at home, because there will be something there for them. They won't be taking carers leave because they've fallen over, because actually they've become stronger through their exercise programs. So I think it's a win-win to say to the local businesses, we would really value you putting your corporate social responsibility funds in our direction, because there's definitely a mutual benefit in that. And don't ever forget the business sector as a part of our complex adaptive system. I think we tend to leave them out. We need to bring them in, because that's going to be the only way we really shore up our voluntary sector, I would suggest.
Awesome. Well, thank you. And I think just to keep us all on time, let's call that a wrap. We hope you enjoyed today's session and were able to find motivation and meaning in all of the great work that's being done, whether it be in your own local level, national, international. We look forward to continuing the conversation, and we'd like to invite all of you to be part of that. We have an interprovincial social prescribing community of practice. Some of you may have seen an invitation for that come across your inboxes. We would like you to join us. This is co-hosted by the Alliance for Healthier Communities, Sonia, myself, United Way British Columbia, and the Older Adult Centres Association of Ontario. Our first community of practice, this interprovincial community practice, is being held virtually Friday, October 29th at 9 a.m. And I believe Wingsy Armand is going to post a link for that in the chat. As I mentioned at the beginning of today's webinar, this is a teaser for our Provincial Summit on Aging, which takes place, again, hopefully in person in April of next year. Please watch for registration details in the Healthy Aging newsletter, Core BC, an invitation that will come through your email box possibly, and those should be sent out next week. And part of that invitation will include registration for a social prescribing pre-conference workshop. This is a half-day event the day before the Healthy Aging Summit. Again, invitations for that will be coming out next week. I want to thank, finally, our three panelists, Marianne, Sonia, Grace, for being here and sharing your journey and the stories with all of us. And a final thank you to all of the participants for taking time out of your busy day to join us today. Thank you, everyone, and bye for now.